ब्रिजेश हो
मुंबई इंडियन्स बॅक टू बॅक खेळते.
हो आता ब्रिजेश आहे का बाजूला? रोहित गेला?
नाही रोहितच आहे. हा काय काय करा ये रोहित.
अरे रोहित भाऊ काय म्हणतो?
ऐकायला नाही असं
काय मग? घरीच बसलोय मी म्हणून असा टी शर्ट मध्ये घालून बसलोय. दिसतोय काय मी?
नाही तुम्ही गायब झाला.
अरे माझं ते हँग झालं आय थिंक हे कॅमेरा. दिसलो आता आय थिंक. ऐकू येते की नाही रोहित? हा काय मग काय लंच काय मागवला बाहेर ना स्पेशल आज काय?
काय आता काय बघू आता संदीपच.
अच्छा
संदीपकडून पार्टी.
हो मग टीमला पार्टी दिली का प्रमोशनची काय? अच्छा नाही आता जॉईन करतात ना ब्रँड पेंटर सर टाइमला वगैरे टायमिंग मध्ये कसं आहे?
एकदा ब्रँड सरांना फोन करतो.
अच्छा करतायत जॉईन?
हॅलो
हा जॉईन करतायत सर म्हटले का?
हॅलो
हा हॅलो जॉईन करतायत सर म्हटले.
10 मिनिटात हो 10 मिनिटात.
ठीक आहे मग तुम्ही लॉग आउट होल का नंतर 8:15 पर्यंत?
मी काय काम करतो ना मी रोहितला बोलतो ही लिंक वरून जॉईन करा. हॅलो
हा रोहितला काय म्हणताय तुम्ही?
रोहितच्या मोबाईल वरून ह्या लिंक वरून जॉईन करून ठेवतो.
चालेल मग क्लोजिंग मीच करू ना कसं म्हणजे?
हा क्लोजिंग करा ना काय प्रॉब्लेम.
चालेल ठीक आहे.
तुम्ही करा. मग बाकी काय लागलं तुम्ही काय डिस्कशन झालं तर आम्ही आहेच.
हो हरकत नाही. आज का मुक्काम इकडेच काय दुपारपासून?
इकडेच आहे आता हल्लोच नाही हलायला झालंच नाही
आता 10 वाजेपर्यंत इकडेच सर आले.
10 वाजेपर्यंत इकडेच.
डॉक्टर आले.
हॅलो हा सगळं ठीक आहे ना म्हणजे येते ऐकू?
सर व्हेरी हो येते व्यवस्थित.
ओके आय जस्ट गॉट अ कॉल आय जस्ट अटेंड टू दॅट. ओके ओके
सर तुम्ही फक्त म्यूट करा आणि यू कॅन बी अराउंड देन आय विल कॉल यू. परफेक्ट नो प्रॉब्लेम. Hi sir, good evening. कौस्तुभ सर, गुड इव्हनिंग. आवाज येतोय का सर? तुमचा म्यूट आहे वाटतं, जरा चेक करायचं. Chetan, just check.
Sir, your
sir's
voice
voice
is audible. No, sir, not audible.
Can you hear me now?
Yes, yes.
Perfect. Super.
Audible, sir. Audible.
Can you hear me now?
Yes, sir. Audible, sir.
Yes,
I can hear you.
Audible? Good. Okay, thank you. Has everybody joined in?
Oh, डॉक्टर केळकर आले.
अच्छा.
ब्रँच जॉईन करतायत.
Okay, no problems. I'll mute myself for the time being.
Yeah, perfect. No issues. हॅलो ओमकार साहेब.
Yes, sir. बोला ना.
ती स्लाइड शेअर करता
स्क्रीन वरती शेअर करू.
तुमची वालीच. हो, दॅट वॉज बेटर आय थिंक.
ओके.
Because we are not aware whether Rancher has prepared any slide.
Not aware. Sorry.
Whether he has prepared any slides, any specific alteration he has.
Okay, branch, sir.
So
Okay.
we'll show our slide only.
Yes. The combined slides, no, of the cases.
Oh, the earlier 10 slides which we had prepared, that was better, I think.
These are the 10 slides on the cases. Visible, na, Sandeep sir?
Yeah.
हाय कौस्तुभ, काय म्हणतो?
कसं आहेस?
ऑल वेल यार. कसं म्हणजे दिस इज बिकमिंग ऑक्सिजन नाही है करके टेन्शन. अरे ऑक्सिजन नाही आहे म्हणून सगळं काम, रुटीन काम बंद झालंय. रुटीन
सगळीकडे झालं ना. आमचं तर सगळं हॉस्पिटलच घ्यायला निघाले होते कोविड म्हणून. शेवटी आता
भयंकरच झालंय. इट इज टू बॅड रे.
But I think one of the reasons is because people just want to get into the hospital even if they don't need to be in the hospital. That is the biggest problem.
Absolutely. But there are people, I'm going bonkers because I'm telling you, within last 3 or 4 days, at least I have arranged for 10 patients. Arrange manje just trying to inquire about them in this facility or that facility, or telling people, looking at their reports and telling, sorry, there is no bed available anywhere. I have tried here, I have tried there. असंच चाललंय रे. It's so boring.
Other thing is this remdesivir जे आहे, everybody thinks that it is a bloody godsend. Yeah, it is. What people don't realize is that it's not the be all and end all of the treatment. Yeah,
Absolutely not. And the same old ignorance continues. Nobody really knows how to go about it. But at a company, pharma people, one gentleman from another pharma called up this man, sir, Tosi arrange karo na kahin se, please. Tosi
is the most dangerous bloody drug here.
Because if Tosi is thought of being used, then that patient is really serious, right?
He is very bad.
Because Tosi is not available. मग आपली classmate आहे ना, शीला सावंतचा तिचा मला long लचक WhatsApp आला होता, and long and short of it was, where can you get Tosi? I said, don't worry, it's not, if it is not available, don't worry too much. That's not going to be something.
Absolutely. Use steroids.
Patient on steroids तो ठीक है ना, बस हो गया ना. अभी वो सब लोग सब मारते हैं.
लोकांचं मत झालेलं आहे की रेमडेसिवीर आणि टोसिलिझुमॅब इज समथिंग विच इज ऍब्सोल्युटली म्हणजे एकदा दिलं की अमृत मिळालं लोकांना.
अमृत वाटतं लोकांना.
नाही मी आजच मी ऐकतो, आज आय डोंट नो वेदर यू हॅव सीन दॅट ऑर नॉट. मी एक व्हॉट्सअप आपल्या शाळेच्या ग्रुपवर टाकलाय. अरे लोक इकडे मास्क शिवाय फिरतायत. मी त्यांना सांगितलं 20 in their 20s, आणि मी त्यांना सांगितलं, म्हटलं बाबांनो नका मास्क शिवाय फिरू. तर मला सांगतात वी आर फ्रंटलाईन वर्कर्स. म्हटलं जस्ट फॉर इन्फॉर्मेशन, आय एम ऑल्सो टेक्निकली अ फ्रंटलाईन वर्कर अँड आय एम वेअरिंग दिस मास्क 10 hours a day. एक शहाणा मला सांगतो की बरे पण सर तुम्हाला माहितीये का किती त्रास होता मास्क घालून फिरायला. म्हटलं मग घरी बस, खाली उतरू नकोस.
Exactly. Hey, Brian has come. Hi, Brian.
Hi, Brian.
Hi. They have started here. Mumbai Indians have started batting. Let's also bat fast.
Yeah. अच्छा, Mumbai Indians match है क्या? Okay.
Oh,
yes.
When the toss chose to bat.
I'm completely disconnected from cricket.
Hi, Kaustubh.
Hi, Brian. How are you?
Good. I'm in your hometown, Goa.
Oh, you're in Goa? Oh, nice, sir. I have not been there for two. Your hometown also. Why my hometown?
Not your.
Our hometown.
I told our hometown.
I'm not far away. I'm not far away. I'm supposed to be from Malwana.
Yeah. Okay.
But at present, you are in Mumbai. Unfortunately,
very much in Mumbai. With KM background showing.
Yeah, I know. I can see that.
So how are we going to start? Some debate or something of that sort? It's a case-based approach.
There are some slides they have given. Let's start
Sir,
with the slides.
Sir, we have two cases to present. Yeah.
Yeah, tell us.
So
Girish.
first I'll introduce you and I'll hand over the session to you. Then you just set a contest on antithrombolytics and ACS and NOACs. After setting the context, I'll highlight the first case.
Okay.
And then you can take the first case. You can take the opinion of entire panelist, whatever pros and cons are there, and then you can summarize.
Then I want you to do. See, I am here in Goa, so you'll have to put this thing up. Okay, you'll have to put the slides. You understand?
I'll put it.
Yeah, you'll have to forward the slides. Then I'll take their opinion. Okay.
Perfect. So slides are there. Are you? It is visible to you?
Yes, very much.
Yeah, slides are visible.
Yeah, perfect.
They're visible.
Perfect, sir.
Just go.
So we'll have a discussion around 20 minutes on first case, 20 minutes on the next case, and then we'll stick to the timelines.
First case is Praful and me. Second case is I don't know.
Dr. Manoj Mashru and Dr. Ramesh.
Are they antiplatelets are also there? I saw
first is antiplatelets.
First is antiplatelets.
First case is antiplatelets.
Antiplatelets, yeah.
But after taking the opinion of Kerkar sir and Vaidya sir, you can take the opinion of the rest of the panelists also.
Okay. Okay.
So that they also be involved.
Fair enough.
Yeah. So I'll just give me a moment. Let's just connect to Dr. Mashru and then I'll get back to you and we'll start off.
Let's keep this to the 45 minutes to 1 hour, totally.
Sure.
Let's
Perfect,
not
perfect,
extend
perfect.
beyond.
No. Within 1 hour, we'll manage the show.
Yeah.
Close to 50 minutes.
Hi, Brian.
Yeah, hi sir, good evening.
Hi, Manoj.
Manoj sir, something
Hi,
is
good
there
evening,
in
Manoj.
front of your camera.
How are you?
Oh, all good.
Perfect. Brian sir, so with your kind permission, I'm going ahead. All are there
Please.
on the platform now. Yeah. So Omkar, just make it live.
Yeah, Chetan, we can go live now. Huh?
Yes,
Perfect.
yes.
Thank you so much.
We can
So,
start.
very good evening to all the doctors. I am Sandeep Kamble. I welcome you on the behalf of Alchem Laboratories, the India's fifth largest company. I welcome the eminent moderator and the panelists and all the doctors who have joined us for this today's antithrombolytic debate. At Alchem, it is always and been endeavor to partner with the healthcare professionals and will certainly continue to do so in coming days. So to help us to navigate this meeting, the debate, we have with us a renowned cardiologist who doesn't require any introduction, none other than our sir, Dr. Brian Pinto sir. So welcome sir to moderate today's debate. Uh, we
Thank you.
have a brilliant, eminent panelist to take care of the interaction on the two cases on antithrombolytics. So we have panelist number one, Dr. Kaustubh Vaidya, sir. Welcome, Dr. Vaidya, as a panelist. And we have second panelist of the day, Dr. Prafulla Kerkar, sir. So welcome, Dr. Kerkar, as a second panelist. We have, for the second case, we have two more panelists, Dr. Manoj Mashru, sir, and Dr. Ramesh Tabar. So this is the plethora of our eminent panelists. And with this small introduction, I request Dr. Brian sir to initiate the program for us today. Thank you so much.
Thank you very much. And thanks to Alchem for giving us this opportunity to be able to discuss these newer agents. I think the context is already known to everybody. And what we are really going to look forward to is an exciting, not debate, but an exciting discussion on the various aspects of the antiplatelet drugs that we've been using for quite some time. We're going to talk about the antithrombotics, including the NOACs. And I think we have two cases which are going to be put up for discussion. So without, spending too much time on explaining to you about all the rest, I think we will start with the first case. We have two panelists, two very senior people, colleagues of mine, Dr. Praful Kerkar, who was with me at the KEM hospital when I spent a short time over there, and even Kaustubh was there at that time. So both of them are, experienced cardiologists, interventionists, and would have extreme knowledge. Many of them have been participants in the trials. So I welcome both of them to the first case. I'll introduce the other panelists at the time of the second case. Now, this first case is a typical 72-year-old gentleman who's presented to us in the emergency department complaining of a sudden onset of chest discomfort for the past 1 hour. And it was typically cardiac. He's been a smoker, not a diabetic, with some hypertension. And his ECG reveals an extensive inferior wall myocardial infarction. So I suppose there's an RV infarct also, and there's possibly a posterior wall when we say extensive inferior. His cardiac biomarkers are actually positive. We usually use it for prognosis when there is an ST elevation, because that really doesn't need a diagnosis from that. The blood pressure was quite well maintained, fortunately, and the pulse was not very fast. And possibly the patient is ready for intervention. So let's have the next slide, please, and then show the ECG, I think, in the next slide. Can you move the slide? Yeah, now this is the slide. And so out over here, I'll bring the panelists in directly and, ask them what they think about this situation, this inferior wall infarct. What would they do? This is a 72-year-old man. Would somebody like to thrombolize him? Would somebody like to take him up for intervention? What would be their initial approach? Over to you, Praful, first. Hello? Is Praful there?
Sorry. Yeah, I'm here.
Yeah. So
Sorry,
Praful, this is the ECG.
Yes,
this guy's come up in 1 hour's time. Yep. Now he's ready for intervention. He's 72 years old and he's a smoker. Now, any thoughts on this? But because we'll go step by step. Yes. So any thoughts on this situation first?
Yes, he is obviously got an ST elevation myocardial infarction. Now, when it comes to, and because there are ST elevations in 2, 3 AVF, we always think about an inferior MI. And in the context of an inferior, also there are, if you see ST elevations, V4 to V6 also, sorry, V3 to V5 and V6. And there is a reciprocal ST depression in AVL. Here it is so obvious, the ST elevation. Sometimes you just might get tall T waves, and that reciprocal ST depression in AVL is really a giveaway in terms of being an inferior MI. And then you
also
ST
Praful, I want to ask you here, when you have ST depression in 1 and AVL, do you almost always think that this is a right coronary artery that is involved?
Yes, that is definitely so. The other more important thing is that ST elevation in 3 being taller than in AVF, here you can see.
Then in 2.
Yes, then in lead 2. Sorry, in 3 more than 2. That is another giveaway. Now you have prognostically a very bad sign out here in the sense that there is ST depression in the anterior leads also. Okay, so generally that is could be associated with a multivessel disease, or it could be just a reciprocal coming from the posterior wall. One other thing one would like to, in such a scenario, have is a right-sided chest leads, which aren't here. But at least in that lead V1, we don't really see an R, a taller R, which would be again a thing that would suggest that you have a posterior infarction as well. So here it is an inferolateral MI, as you can see it, and my bet is that this will be an RCA MI. In terms of management,
I think we would take right-sided leads in all these patients.
Absolutely.
Praful, we would take right-sided leads in all these patients.
I think all patients with inferior MI should get a right-side chest.
Right-sided lead. It should be standard
whether
procedure.
the changes are there or not.
Right, right. Exactly. This is what I think we need to say, that this ECG is incomplete without the right-sided chest leads. So I think we have, Praful has given us a wonderful thing about why the localization of the ECG showing the inferior wall and you look at the anterior wall, and you look at the true posterior, and you look for RB, and you also look at what are the reciprocal changes. So he has given us. So can we have the next slide, please? So here is the question about the antiplatelets and their dosing. So here I'm going to put it up to Kaustubh right now. Aspirin, of course, with clopidogrel, aspirin with 600 milligrams of clopidogrel, aspirin plus prasugrel of 60 milligrams, or aspirin loading with ticagrelor of 180 milligrams. What would be your choice over here? I think at point of contact, we would all want to give this
Personally,
patient
I would go with a aspirin loading dose with ticagrelor of 180 because that's the fastest acting. The patient is willing for intervention. And if I'm going to take up the patient for intervention and this, I would prefer, especially as a smoker. So the platelet reactivity is likely to be more than normal patients. Luckily, it's not a diabetic. So I would like to have the platelets inactivated as much as possible. And the fastest inactivation comes from ticagrelor. So I would prefer to give him aspirin along with 180 milligrams. That's 2 tablets of ticagrelor right away before I take him up on the cath lab table.
Yeah. Praful, any thoughts on that, or you go with the same thought process?
I'm taking your word for it. Ready for intervention, meaning you might have taken the time off, and depends upon the scenario as to where you are seeing him. Whether he is at a periphery, where is he in your ER, or whether he is in an ambulance for that matter. And in terms of that, he definitely needs a second antiplatelet agent. There's no doubt about it. But when in doubt about ready for intervention, but here more than ready, what we also need to look at is other things also. We need to look at the reimbursing monies, where it's going to come from. Like whether it's a private setup or a university hospital setup, wherever you're looking at, between the cup and the lip, there is a lot that's happening. Let's not forget that if for instance, in our esteemed audience, there are not necessarily only cardiologists, and if say there are physicians who are dealing with MIs also, and in that scenario, as a blanket policy, what should be given to this patient in an EMS scenario? Okay. So yes, therein also, at least, and not everybody in an EMS scenario or in the ambulance knows to interpret even an ST elevations. This is absolutely an overt ECG. Sometimes they are not as overt. In that scenario, the first choice that has been given, aspirin, a chewable aspirin plus 300 milligram loading dose for a cardiac chest pain, definitely needs to be given. But going along with what Dr. Kaustubh Vaidya says, in the scenario that everything is ready and everything is there, then a pre-treatment with ticagrelor is fine. But otherwise, also, even if you have not pre-treated with ticagrelor yet, and if you are, say, pre-treated because a physician has given, say, 300 milligram of clopidogrel, which is usual to give for any ACS, and then one can always switch to ticagrelor even in the cath lab when you have taken the patient to the cath lab. So
I think, Praful, you brought up a very, very important point because when you say ready for intervention, we mean where is the patient? Is the patient in your hospital where the cath lab is ready, or whether he's in the ambulance, or where is he? Is he 4 hours away?
Slide that he has presented to the EMS. So I assume
yeah. But is he in the EMS? Is he ready for intervention and EMS, which has a cath lab? All those points. Now, we are all used to EMS, meaning Jasloke Hospital or Bridge Candy or Saifi or wherever. But there could be an EMS which does not have a cath lab. So now when Praful brings up this point, I think it's valid. Now let's say that the EMS is an EMS where the cath lab is not available. If that is not available and we are thinking of thrombolizing the patient, then I think the maximum data is there with clopidogrel. So if you're going to thrombolize this patient because he's less than 75 years old, you would still give him at the dose. It's a very fine cut line. If he's very thin and all, you may even reduce, but otherwise 300 milligrams of clopidogrel with the thrombolysis. Ticagrelor has some experience with thrombolysis, but it's extremely small. However, that experience with thrombolysis is after a few hours after the thrombolysis was administered. There was a trial in South America, which not exactly a trial, a registry, which showed that you could use ticagrelor with a slightly higher risk of bleeding with thrombolysis. However, our maximum data is with 300 milligrams of clopidogrel. And this I want to mention clearly because when you're thrombolizing, it should not be 600 milligrams of clopidogrel. It should be 300 milligrams of clopidogrel. So if you are going to give 300, then as Praful said, in the cath lab, you can change over to ticagrelor, or at times even prasugrel. There's a question mark over there when you've done the angio already and you want to switch. That's your choice, because you then have some data to suggest that even prasugrel could be included at that point in time. However, there is a point for giving clopidogrel still in some situations, but as Kaustubh pointed very clearly, when it is an EMS that has a cath lab and the patient is willing, I would go with his statement and with his answer that ticagrelor would be the obvious choice. And I think Praful also agreed with that. Let's go to the next slide, please. I can't see the slide very clearly, boy. Yeah, okay. Now we've come past this. Now, dabigatran, we've already come to this in non-valvular fibrillation. Is this the second patient?
Second.
Or are you including dabigatran here in patients who have ACS and also got atrial fibrillation? What is this slide?
Thankfully, our patient is in sinus rhythm.
Sinus rhythm, exactly.
And with no AV blocks.
Yeah, so this is in sinus rhythm, okay? Now, but if the patient was in atrial fibrillation, you would still administer, even if he was on anticoagulant, you would give him aspirin and you would give him clopidogrel, and then you may take off the aspirin as quickly as possible. But initial period, you would definitely give him both the antiplatelets, even if he was on a drug like dabigatran. No question that if he had an ACS, you would certainly want to use the antiplatelets with a little higher risk of bleeding, of course. And you may moderate your dose of the antiplatelet. Instead of giving 150 milligram BID of dabigatran, you may cut that down to 110 milligrams of dabigatran during that period. So where are we going now? Which is the next slide you're taking me to? Hello.
So this was actually the first case which we are discussing right now.
Yeah,
and
okay.
then we are moving to the second case, which is on dabigatran.
So then we can now actually, in my opinion, we can have a little more discussion on we hardly had any significant discussion on the antiplatelet. So let's bring in Manoj Mashru over here and go back to the previous slide. Manoj.
Sure, sir.
Manoj, you're there? Hi, Manoj. Why don't you get Manoj Mashru in?
Manoj must be under the impression that he's to come in for the.
No, he's coming. Yeah, but they said that they could come in for the first case also.
Yes, sir. I just check. You can go ahead.
Yeah, is Ramesh there?
Yeah, he's there. He's there.
Can he come in?
Yeah, Dr. Manoj is there, sir.
Hello.
Hello, Dr. Manoj. Can you?
Yeah, Manoj, you're there?
Yeah. You're still on the first slide.
So did you hear this discussion on the antiplatelet drugs, or you were doing cath in the meantime?
I have 3 COVID patients in the ER.
Okay. So now tell me, if you
CT
were
score of 21, 18.
Yeah.
Okay.
Now this is the antiplatelet.
Go back. Huh.
You went there to do angio in the COVID patients.
The phone calls don't stop now, but the patients know they have to manage now.
Okay. So here's the thing. Would you use, when the patient comes to you in the emergency room and you have an ST elevation myocardial infarction, would you with aspirin use ticagrelor, clopidogrel, or prasugrel? Now let's say in your ER, he comes to your ER and he's ready for intervention.
So our ER, I think it's almost 90% plus it is ticagrelor.
90%?
Plus it is ticagrelor.
Okay. But if he comes, if he's dilly-dallying, he's not willing for intervention, family is calling United States, and then you're thinking that you may have to thrombolize because there's no answer coming. Then what?
No, see, the other thing is actually there's been also a small but definite data that ticagrelor may increase the bleeding risk, but again, it is not that high.
No, that I agree. That's
not that high. So I see where we strongly feel that probably we are going to go ahead, we just go ahead and give ticagrelor.
Okay. But if you're feeling that the patient may not and you have to thrombolize and relatives, then you may use clopidogrel along
Then we
with
clopidogrel, and then again after that also
Shift.
we give ticagrelor.
ticagrelor before the cath lab or in the cath lab.
Yeah.
So I think that was what we all discussed. And so now we come to the second. We wanted your opinion. Ramesh is there, then he can also give us an opinion what he would think. Okay, otherwise we go to the second case.
Yeah.
Take us to the second case, please. Now, this is dabigatran in non-valvular, newly diagnosed atrial fibrillation. So when we're talking about non-valvular atrial fibrillation, the only two entities enter the picture of valvular. One is severe mitral stenosis, and the second is a prosthetic valve, which is a metallic valve, not a bioprosthetic valve. I have given the NOACs in bioprosthetic valves, and I was part of the study for edoxaban, where I had 3 patients who were with bioprosthetic valves. So it is not the inclusion of bioprosthetic valves in non-valvular atrial fibrillation, and it is not the inclusion of mild to moderate mitral stenosis. So we must know that. And now we come to this place where we're talking about a 55-year-old female who presented in the OPD with a history of palpitation, lasted approximately 15 minutes, and had a similar episode 3 months back. She's a hypertensive, and she's been on telmisartan for about 40 milligrams, but is irregular. There's no diabetic history and no history of CVD, nor has she had any history of major surgery. She belongs to a middle-class family with vegetarian habits. She's not on any antiplatelets or anticoagulants earlier. Her blood counts are normal. Her renal and hepatic functions are okay. Thyroid function is okay. ECG at rest is normal, but ECG must have shown something at some point. 2D echo shows normal valves and chambers. LV contractility is 55, no clots or vegetations, and or pericardial effusion. So this is the echo, the ECG, the history, and she's had these 2 episodes of palpitation. So you're going to take us to the next slide after this. Let's go to the next slide. So her clinical examination showed a blood pressure which was in the normal range. The pulse was regular. All her systems on examination were okay. The advice for a 24-hour Holter monitoring, but sometimes maybe we would monitor more than that, more than the 24-hour monitoring for the Holter. And then you looked at Holter report showed a short run of AF, approximately 10 minutes. So now, Manoj, this is your take. This is a lady who's 55 years old. Hello.
Yeah, Brian.
Yeah.
Yeah, it's a difficult decision in this lady.
Yes.
For 2 reasons. One, that she's 55 years of age with normal left ventricular function. And although she is supposed to be hypertensive, but one, she's irregular with treatment. So I don't know whether the blood pressure of 122 is without medicine or with medicine. And secondly, even the AF episodes are very short. So I think it's a borderline situation. Although theoretically you can say that she's a female and she is hypertensive, then the CHA2DS score becomes 2. But I think it's debatable in this lady. Yes,
Would you do a longer Holter in her?
Yes, I'm just coming to that. So
yeah.
So obviously even the AF burden doesn't appear to be significant. So one, I would like to find out whether there's anything which could have caused this AF episode, find any precipitating factors. If not, then maybe ask for a prolonged Holter, and then still observe unless she's had an event. And obviously from history, she doesn't seem to have had any event. So I think this patient is kind of borderline. As a purist, you can say this score is 2, but to me, it is still not convincing to put the patient on a lifelong NOAC in such a case.
It's very borderline. What about you, Ramesh? What do you think?
Yeah, now this lady has only 2 episodes of palpitation. One was 2 days and one was few weeks back. She investigated echo is normal. Yeah, his size probably on echo should be normal. And as regards the blood pressure also is reasonably, of course,
Good
we do
evening.
not
Sorry, I'm in a meeting. Can I come
on
in later? Something urgent?
drugs on. First thing, pull out hyper, of course,
Hello?
not a very considering that our heart rate is normal. But one thing we can rule out is to do a thyroid function test. But with regards to the use of anticoagulant, I also feel the same, that we do not have a strong evidence in favor of anticoagulant for lifelong for this patient. We have more data, as you said, by doing longer halter. And if we have frequent episodes of atrial fibrillation, then probably I might change the strategy. But as of now, we'll like to observe her and then see whether we should start anticoagulant therapy.
But certainly all of us agree to a longer Holter monitoring in this patient. Would you not agree to that? I think all of us
Yes,
think that we need to know more about this patient. If she has frequent episodes of atrial fibrillation during this periods of longer Holter, then I think we may swing in favor of the NOAC, but certainly not with just this one occasional episode. And we would also try to look for any cause for this particular thing. For example, if she had a bout of fever, or it's a lady, of course, but she could have had a bout of alcoholism also. You have to check all those things. There are so many causes for atrial fibrillation, which may be stimulated by certain events, which may not be necessarily the need for putting this patient on anticoagulant NOAC. So can we have the view of Praful and the view of Kaustubh also over here?
I think I agree with Manoj what he said, because this is a too short a run, and this is too borderline a case to put somebody on something as drastic as
Yes.
oral anticoagulant, which may go on for a minimum of 6 months or maybe a lifelong. So I would like to get her investigated better, and then if required, put her on NOACs.
Yeah, if required.
I couldn't agree more, but I would like to hear also keep her on a closer watch, given that she has documented AFib on a Holter. As also we would like to look at the echo in a better way, meaning like
look at the LA
size,
volume
volumes and all also need to be looked at.
Absolutely.
Because it should not so happen that her first presentation is out of blue a stroke.
Yeah.
It's good
So
that
I think you're right. You're right.
A
You're
close
right,
watch is important here.
Yes. So now, can we go to the next slide? Can you show me the next slide? I can't see your next slide.
We have discussed the first point already.
Is it visible, sir, the next slide?
Yeah.
Yes.
Points to be considered. Yeah.
I think somehow Brian sir got disconnected.
Yeah, I think Praful can take over, but
to set the context out here, the other questions become relevant for Dr. Ramesh as well as Dr. Manoj, since you are the experts out here. Say she had some little cerebral symptoms, okay?
Or the patient's age was 65.
The age was 65, or that she had some cerebral symptoms, okay? And now that she's been explained in details and she's come to you for a follow-up, and you land up because of some cerebral symptoms, somebody's done a CT somewhere, and she has some little bit of a, so like she could very well be
You decided to put the patient on NOAC
so now you have taken a decision that it's plus minus. Now I'm going to give a NOAC. So now let's go with the questions. Since till Brian is not around, I would ask of Dr. Ramesh, if yes, then which anticoagulation would you use for stroke prevention and atrial fibrillation for this lady? Now, would you want to go with a VKA or would you want to go with a NOAC? And if so, why for each one of the two? Or whatever you want to go for.
Okay. Now, since this is a non-valvular atrial fibrillation, I will definitely go ahead with NOACs rather than vitamin K antagonists. But that again will depend upon the affordability of patients, whether patient can monitor regular INR, PT INR, how good Cs at compliance with the medicine. But considering all the data, since this is non-valvular atrial fibrillation, I still would prefer NOACs instead of VK, because we have enough data from various studies using various NOACs like RELY, like Rocket AF and Aristotle. All these trials, big trials, have shown a definite benefit of NOACs over vitamin K antagonists. So that would be my choice. Now, amongst NOAC, there is no specific drug which is required. We can use any of the NOACs like dabigatran, rivaroxaban, apixaban, all because looking to her history, there is no bleeding. The renal function is okay, hepatic function okay, so Has blood score is not high, and we can use any of the NOACs.
Okay. So
Yeah.
but your preference.
How
Yeah,
long?
Brian,
Praful,
Brian.
How long should we continue?
Okay.
Once we put her on.
I think it should be minimum for 6 months, but I would prefer lifelong because we do not
I
know.
think once you put the patient on a NOAC, unless there's a reason to stop the NOAC, I don't think you can stop the NOAC, because if you have decided that she's a case of atrial fibrillation, whether it be paroxysmal or it be persistent or whatever, you are now going to keep her on a lifelong NOAC unless there's a reason to stop it. For example, she develops excessive bleeding and she's on the borderline situation. Otherwise, you would not stop the NOAC, or you would change it or whatever, reduce the, these kind of things.
Yes,
I don't
yes.
think it's like for 6 months
So
or
you
anything of
decide
that
to
sort.
beforehand only if the patient deserves NOAC, then obviously it should be continued lifelong.
It's lifelong. It's lifelong. I just want to bring a point over here that the people who benefit the most from a NOAC are those who have the highest risk. For example, when you get an 85-year-old lady who's in atrial fibrillation, that's the time we get scared to give a NOAC also, But those are the patients who have the maximum benefit. Those are the patients who have the maximum benefit. So I don't think in any way we can say to anybody that the NOAC is not to be used. The NOAC has to be used for a lifelong. And the age of the patient, in my opinion, doesn't make a difference to the use of NOAC. If your patient is very old, even is 88, 89, I think dose related, depending upon the renal function, the creatinine clearance, all those facts, you adjust the dose, but they will get the maximum benefit from the NOAC. Those who have the highest blood scores also have the highest CHAD-VAS scores or the highest CHAD scores. So that's important. Now, Manoj, how does cost of therapy impact your patients? I know you're in a hospital, which I think cost of therapy does, but you've also been in the municipal hospitals, so you know that cost of therapy makes a difference to patients at times. So
Brian, I still see patients in free OPD, and we still see patients from.
Okay, I thought you only see rich patients, so I was not wanting to ask you that question.
Not like Brian. Yeah.
Come on, tell me, how does cost of therapy impact patients?
No, so I think it's just not the cost factor, but also the follow-up factor that needs to be considered. So sometimes we find that the patient may not be able to get proper PT-INR reports coming from different places. In fact, I would encourage such patients. And today, cost is less of a problem because of the Indian substitute medicines available.
They have brought out wonderful products. Do you know
so
that
now I think this
Alchem's
discussion
Dabiplot,
is less.
yes, less relevant.
Discussion is less relevant in current times. So I think in most patients, I would still prefer NOAC.
Yeah, I think today Dabiplot, as they have produced for us, is got a equivalence to the original brand. In fact, correct me if I'm right, it has got it has got an approval in the United States of America. That's what I have been given to understand.
Right.
That it is branded. It is also used in the United States of America as a generic drug. Am I right or wrong, Alchem people?
Right, sir. Correct, sir.
Hello.
Right, sir.
It's correct.
Yes,
no?
Correct, sir.
Correct, sir.
So basically, it has been Yeah. So I think there the cost of drug and even rivaroxaban has come down in cost so much that I don't see why we should be using VK antagonists in place of these NOACs when they're so much better, easier, no food drug interaction, and the ability of the patient not to get intracranial bleeds. VK causes so many bad bleeds, especially intracranial bleeds. And I think I would not use VK on my NF also unless he has to use it. So drug food interactions are much less. Of course, renal clearance is important to many of the VKs. And I think, Praful, I think I'll ask you a little bit about the when you have a renal problem. I'm not taking this patient alone, but when you have a patient whose eGFR is coming down below 40, 30, then what do you do?
See, now, because the NOACs are off patent and we were discussing cost. Now, for this particular patient, dabigatran, 150 milligram BID, because we've also talked about the cerebral symptoms and a possible TIA type of a picture. So that would be my drug of choice. And NOACs would be still a class 1. But if it were to come that her renal functions were impaired, is what you just put out to me, then I would stay away from dabigatran. It's simply because dabigatran is about 80% cleared by renal. And if cost were not an issue, then the least clearance by the renal route is of apixaban. So then my choice would be, and again, rivaroxaban, there is a lot of data also. About going
but apixaban has a better data for renal. I agree with
Exactly. So I would have gone in for apixaban. Okay.
Yeah.
But then if cost is an issue, then rivaroxaban, since it's off patent and available here at a cheaper cost, then it would be rivaroxaban. But I very much agree with all of the rest of the speakers as well as with you that we should somehow keep VKAs away from this patient. And it is today, even indication wise, a class 1 that NOACs are said to be superior in terms, they are class 1 over your other two, over VKA. That is there definitely.
Now the other point I want to make, which I brought up and I think is so important, the drug and the drug food interaction. Kaustubh, I want your input on that. I would hate to have a drug where I cannot eat something, I cannot have a drink, I'm not allowed to do this. Then Kaustubh, how do you take that? Means for me, a VK is a no, absolute no. I had many of my patients in the early days not allow me to put a prosthetic metallic valve in them because they told me when I had a discussion with them that they would rather live their life with eating things properly, drinking things properly, rather than live this kind of life. So what is your intake about this food, drug and drug interaction?
Yeah, NOACs are much better as compared to VK when it comes to even drug interactions as well as drug food interaction. And the only reason why you would probably go on to VK, as Dr. Praful says, is because of grossly impaired renal dysfunction where the eGFR has come below 30. Otherwise, I would prefer NOACs over VK undoubtedly.
Yeah, so I think we brought in a good point over here.
Vegetarian. They have purposely said that the food wise she's a vegetarian.
That's bad actually. Vegetarian is a bad situation because she gets all those green leafy vegetables are all avoided there. So what about the compliance with the drug? As far as compliance is concerned, do you all think single daily dose is better than twice a day dose? What are your thought processes on the compliance of drugs? And I'll take Manoj's view over here first. What about compliance?
Yeah, compliance is important, but I think very rarely today we look at the drug versus OD versus BD to really prescribe the medication because so many patients of ours, they're not just on one medication. They may be on statin, which may be to be taken at night. We may be giving antihypertensive, diabetic drugs. So I think most of these patients are on multiple medications. So I don't think it's really applicable in most of the patients. Unless a patient is the sort who says, you give me something which is once a day, where I would prefer to give a drug with.
What about old patients who forget? For example, nobody at home, their pill box is there. You get those type of patients also.
But still, Brian, if you see elderly patients, you tell me, are they likely to be only on one single
Yeah, but
NOAC.
they can
No,
be
the
on
patient
one.
is 100%
No, I'm
likely
just
to
telling
be
you,
on
the guy is
multiple
taking his
medications.
he's taking his telmisartan with chlorthalidone in the morning, or telmisartan with amlodipine in the morning. He's taking his diabetic pill in the morning. He's taking his cholesterol pill also. It's allowed in the morning. So he takes everything in the morning. Okay. He doesn't have to remember his pill again in the afternoon or in the evening.
So I'll really have to scratch my head to find out such a scenario where
No, there
I have
are.
to give. No, there are.
No,
there,
there
but
are.
in your day-to-day practice, out of 100, I don't think you'll get more than 2 of such cases where you would need to consider this as a sole
No, I'm just
point.
asking the compliance. Does it matter? Doesn't matter?
It
Praful,
does
your
matter.
take?
It does matter. It does matter.
Yeah.
I would be happy
here,
if
especially
the other
because the
medication
patient
was
has
available
been
and the choice was available
non-compliant with
once a day.
telmisartan.
Yeah,
We have got
people go out
evidence
in
here
the
in
evening.
this
I
patient.
agree. I would go for the compliance definitely because
Absolutely.
of BID dosage in the elderly. But this patient is apparently young, right?
Yeah. Not
So
this
that is
patient.
why
Any
in her
patient.
case it may not
Yeah.
matter as much. But also because more important, forget the compliance part of once daily. The thing is that once you have only a single this thing, the other one, you will forget the other one. But let us also, why don't we discuss the issue that because the others are also available or molecules which are available, all three are available in their lower dose also. And once you have taken, you have a twice a day prescription available. Once you have taken, some patients tend to think that I have at least taken it once a day kind of a scenario. So that kind of a mistake also happens. And that we ought to give, even if we were to give dabigatran here, you ought not to be giving an 110 milligram dose for fear of bleeding.
150.
She necessarily needs
Agreed.
the
Totally
150
agreed.
milligram BID dose.
Totally agreed. If you're giving, give the correct dose, give the proper dose.
Yes.
Ability to do regular monitoring, and here comes in the point of VKs. I find our monitoring systems are very poor here. Even any lab will not give you consistent monitoring data. And when you're talking about the best labs in Sweden, Scandinavia, all these other places, even in them, the time in therapeutic index has been like 70%, 67%. And ours at best in our patients have been close to 50%, those in trials. So I think monitoring for PT-INRs is really very, very tough. It's a tough go. So what are all of your takes on that?
Why don't we involve Dr. Ramesh?
Ramesh, please.
Yeah. No, I definitely agree. The reports which we are getting, to rely on these reports is really, really an issue because labs gives us a different report. The other labs, if you get the other day, you get a different report. So rely on is a problem.
Very, very difficult.
But just
No, it made my life easy, has made my patient's life easy. No monitoring.
Yeah, but it's pretty expensive. I mean, one test comes more expensive than doing it in one of the better labs.
Yeah.
That is the only issue. And second thing is the shelf life of that strips is not great. So it's a big problem.
Correct. Now tell me about, does your NOAC change with cardiovascular risk? Suppose your patient had some cardiovascular risk. Are you worried about giving him VK versus NOAC? I'm not really worried. I prefer to give them NOAC if there's atrial fibrillation. Hello?
Unless the patient has something implanted in his heart.
Like LV clot or something of that sort, or he has something where the indications for NOACs are not yet found, or he has an implantation of a metallic valve, then of course we are using VK in any case. But other than that, I don't think cardiovascular risk changes my perception of using a NOAC. I would use a NOAC with the antiplatelet, maybe one antiplatelet could be clopidogrel on board. And after 1 year, maybe only the NOAC. So if the risk is not very high. And if the risk is high of ischemia, then maybe the clopidogrel would go on for 2 to 3 years or maybe longer, depending upon the bleeding risk also at that time. So I want all of your takes on that as far as that is concerned. I myself do not give 2 antiplatelets with a NOAC, except for the first week or the first month, depending upon the bleeding, because I don't think aspirin beyond a week or beyond a month really makes a difference to the ischemic risk. So and it increases the bleeding risk remarkably. So what are your takes, starting with you, Kaustubh?
Yeah, whatever patients I have done, actually, when these recommendations were not there, I had a patient, a doctor, an elderly gentleman who had an aortic valve replacement, and it's a very interesting story. And he had a bypass surgery because he had an LED lesion which was not plastable. And then he came back in 3 weeks' time, and something funny which nobody probably has ever seen is that his lima got stuck to the posterior wall of the sternum, and there was a tenting, and I had to go down and do a angioplasty. And this patient, we had to put him on because he had a stent and a valve. This is must be about 8-10 years back, and no recommendation. So he was on a triple dual antiplatelet with
That's dangerous.
or VK. That was very dangerous. And poor fellow succumbed to brain hemorrhage after some
that's
time.
what happened.
But
The other
now with
place
the
where I want
recommendation,
the other place where I want to tell all these fellows, stop these gold, whatever gold you'll have started, which is containing statin and both the antiplatelets, clopidogrel and aspirin, that should be taken off the market, in my opinion,
I
because
have been
people
telling
forget
the
to
companies
stop
for
the gold.
donkeys years
They
now.
only want to make money. You have to stop this gold stuff because people don't know what gold contains, and everybody is using that. And I've had 1 or 2 very severe bleeds because of gold, because the patient has forgotten, and some physicians continue this gold business,
I've
which
just
contains both.
last week in the police hospital, there was a police sub-inspector who was had an angioplasty, and I don't know what was the reason. He was on NOAC with this gold business, and he had a huge hematoma on the abdomen. Luckily, he didn't bleed inside or in the brain or something of that sort. And I had to stop all that and put him only on. I have told him to get all the investigations and kept him only on clopidogrel 75 with a small dose of NOAC. But these are genuine problems, and I think I
They
would
must
also
stop. Yeah.
they must stop it.
Yeah. So bleeding versus ischemia we discussed. What about your intake, your content on this, Praful, and then Manoj and Ramesh?
So, yes, meaning we were discussing antiplatelets along with NOAC. For the CV risk itself, if you haven't had a stent or if you haven't had an ACS event, then being just on a NOAC is good enough.
Yes.
You don't even need to give add-on antiplatelet. And if you were to give an antiplatelet,
Yes.
today say this lady were to get a ACS event and you have stented it. So as less as 1 week is good enough, but depending, you will wait.
Correct.
The thrombotic risk and the bleeding risk. Her bleeding risk is not great. So maximum going to a month or so. And then definitely drop the aspirin and then give both the dual antiplatelet as this, again, based on the bleeding risk going up to 6 months or 1 year. And
Correct.
I'm happy to drop the second antiplatelet also. And today we must understand that we have got such good stents and deploying techniques, and most use imaging as well. So we need not worry so much about the stent thrombosis part to use the antiplatelet and just.
I think so. I think so. I think that's a very good message, because we sometimes, and we don't see those patients who bleed. They go either to the neurologist, the general physician, the gastroenterologist, and you may not see them. But doesn't mean, because when I did trials, I found that good number of patients who would have normally I would never have picked up had bled somewhere or the other. But we think nothing happens to them because they don't come back to us. So that's not the truth. The truth is bleeding does occur, and aspirin has no role after a period of 1 month. No role at all in most patients, unless they're a very specific, very high intensity of a bleeding risk. But even in that case, of a thrombotic risk, but even in that case, usually up to 1 month is good enough. So I think there's any more slide to be discussed. Go ahead.
With the current
Ramesh, Ramesh.
Yeah, with the current generation of stents which are there now and the deployment technique which we all use, I don't think there is any role of aspirin beyond 1 month. 1 month with
that is if the patient is on anticoagulants. So please, otherwise people will go ahead and stop DAPT within 1 month. That's
in the context of anticoagulant. That is therapy, triple drug therapy. Aspirin for just 1 month, And clopidogrel may be for, depending upon the bleeding risk, 6 months to 1 year time.
Correct.
And
I
after
think
that,
Praful said that, and I think we are all in agreement to that as much as possible. You know,
Only one more point I wanted to make, Brian. The bleeding versus ischemia. Every patient that gets onto an anticoagulant, you want to also weigh his bleeding risk, and a Hasbled score or whatever that we look at is extremely important. But again, that just because the bleeding risk is high, right at the outset, you mentioned that an 80-something-year-old will actually get better stroke prevention.
yes. That I said right
Every
in the beginning.
80-year-old is high bleeding risk. But
Yeah,
that
because
is-
by the age itself, it's a very high bleeding risk. But you have to use you have to use the appropriate dose, because stroke prevention will be much higher than bleeding. So totally agreed that you must have that in mind.
high bleeding risk should not prevent us from using NOAC.
Absolutely. That's the point. For the last point that they have made here, that is an important message, I think. Yeah.
I think we have covered most of the area. Is there any other slide that's coming up?
No, sir. This was the last slide, sir.
I think we discussed it extremely well. I'm very thankful to all the panelists, Dr. Praful Kerkar, Dr. Kaustubh Vaidya, Manoj Mashru, and Ramesh, and to Alchem. And I'm leaving the last part to the Alchem people to say a few words before we can all discuss.
There is one query coming up, sir. Can I ask, sir? If you,
okay, but keep it to 3 or 4 queries only.
Just
not
one
more.
query, sir.
Yeah.
The query is, can the patient be shifted from ongoing clopidogrel therapy to ticagrelor therapy? If yes, then what care has to be taken?
See, there is a very, very good algorithm that has been given in the acute stage and in the chronic stage. When in the acute stage, you want to shift from clopidogrel to ticagrelor, you have to give the 2 tablets of ticagrelor like you give it in the cath lab immediately, and you continue that as a 1 BID dosage. And there is no worry as far as that is concerned. Even in the chronic stage, when you are going from clopidogrel to ticagrelor, you will always go with a 2-tablet strategy immediately to give up the build-up level, and then you will continue with 1 BID dose. However, when you are going in a situation on the opposite side, for example, when you're stepping down from ticagrelor to clopidogrel, which can also happen in some patients, in that case, you must have a situation where you give 6 tablets or you give 8 tablets, depending upon 4 or 8, depending upon what you want to take. And this happens rarely, but sometimes when you want to switch from ticagrelor to clopidogrel, you have to go with the whole dose of clopidogrel. And the algorithm, I can tell them, is available on the ESC, which tells you the time at which you have to give it. For example, if you stop your clopidogrel in the night, then your ticagrelor you want to start the next morning, you start with 2 tablets of ticagrelor the next morning. However, if you're in an acute situation, you give it immediately and you don't worry about the clopidogrel effect at all. We have given 300 milligrams of clopidogrel, and in an acute situation, you can add 2 tablets, that is 180 milligrams of ticagrelor, and you don't have to be worried about it.
One more point here is that you give your clopidogrel when you're going from tica to clopi. You give your clopi loading at the next time when the ticagrelor was supposed to be taken.
You give the whole dose.
You do not want to wait in between period. 8 a.m., 8 p.m.
Yeah, 8 p.m. You'll give the whole dose of clopidogrel, the 6 tablets or the 8 tablets or the 4 tablets, depending upon what you want to do.
Fine, sir.
Any other question?
No, the questions are over, sir.
Yeah, so why don't you take over?
Sure, sir. So thank you very much to all the panelists, sir. So we take this opportunity to thank Dr. Brian Pinto for moderating this debate and ensuring the audience are enriched with clinically relevant messages. We also thank all our esteemed panelists, Dr. Praful Kerkar, Dr. Kaustubh Vaidya, Dr. Manoj Mashru, and Dr. Ramesh Kavar for sharing the clinical experiences. We also thank all the attendees who have joined for this panel discussion. And we at Alchem Labs would continue to serve doctors and patients by making our products available, that is Tisart, Dabiqlot, and Ticavic. So thank you, doctor, once again for this wonderful discussion and debate. That's all from my side, sir.
Thank you.
Thank you, sir.
Thank you, sir. Thank you, everybody.
Thank you.
Thank you, sir.
Thank you.
Good night, sir.
Ramesh,
Bye, sir.